Good afternoon, everyone. My name is Rochella Watson, and I'm a community lead with the ALS Society of Canada, and I'd like to welcome you to the ALS Canada webinar series. Today's session is on genetics and ALS. So just some housekeeping. Please note that this webinar is being recorded, and the recording will be on our website, so stay tuned. It will be posted in a couple of weeks. All attendees are going to be muted. We do have a toolbar. It's typically on your right-hand side, and you have different sections in the toolbar. So you should have a chat section and you should have a question box section. If you're experiencing any technical difficulties at all, please send a chat message to Melissa Van Tool, and you'll see her in the list here under staff or under the attendees. If you have a question based on the content of the webinar, please type your question in the question box. So you can look in the toolbar, you open up the tab where it says questions, and then you type in your question, and that can be posted for everyone. And at the end of the webinar, we will go through the questions and answers. Our mission at the ALS Society is we work with the ALS community to improve the lives of people affected by ALS through support, advocacy, and an investment in research for a future without ALS. In today's session, we have two esteemed speakers today who know all about genetics and ALS. And today we're going to learn about what that means. What is DNA? How do we inherit diseases? What is a genetic mutation? What is genetic counseling? And how do we access that? What is genetic testing? And what do we do with the results? Of course, there are some ethical considerations when we're talking about genetic testing, and it can have an impact on the family as well as an impact on the person psychologically as well. So we're also going to uncover some of those things to consider. So without further ado, I am going to pass it over to Christiana, who is going to be our first speaker, and you are going to introduce yourself, Christiana. So I'm just going to pass it over to you.
Thanks, Rochella. Bear with us, everyone, for a moment while I get my screen shared. Show this window. I just want to make sure you can see that. I need to do full screen. Can somebody just let me know that you can see it? Perfect. All right.
Perfect.
All right, so Nancy and I will take this away. Just a quick outline of how we're going to go through the content today. We're going to start by talking about genetic counseling first and foremost, because counseling and testing go hand in hand, and you should always have genetic counseling before genetic testing. We'll then move into some genetics 101, like things, what is DNA, how we inherit diseases. We'll go into some specifics about genetics and ALS. Then we'll go into genetic testing for ALS, and finally wrap up with what the landscape is here in Canada. We didn't know if you'd be able to see us or not, so there's pictures of each of us here. I'll introduce myself first, and then I'll hand it over to Nancy, who's going to kick things off for us. My name is Christiana Salmon. I work at the Montreal Neurological Hospital. We have a good mix of patient caregivers and service providers who are attending today. So some of you might have known me or heard of me before. I previously managed our clinical trial program at the Neuro. And for the last 2 years, I've been the National Programs Manager for Genetic ALS at the Neuro, leading a Canadian strategy to improve access to genetic counseling and testing for people living with ALS. And so now I'm going to mute myself and turn it over to Nancy, who's going to start us off.
Hello, everyone. So as for myself, I've been working as a genetic counselor for the past 13 years. Out of those 13 years, I've been at the Neuro for the past 9 years and have been working closely with many of the neurodegenerative diseases at the Neuro, with a special interest in the ALS clinic. So I was involved quite early on with the introduction of genetics for those people living with ALS. And Next slide, Christiana, please. So we're just going to start overall what genetic counseling is, and I typically tend to start that way just because there's not many of us. We do work in the field of rare diseases, and our profession as well is quite rare. Here in Quebec, we're actually only about 50 to 60 genetic counselors, and in all of Canada, we're about 350. I think we're touching the 400 mark of genetic counselors. We are healthcare professionals. We do hold master's degree in genetic counseling, so it's a very, very specific degree. We are specialized training in medical genetics and counseling. After we finish our master's degree, which is only held in 4 different universities in all of Canada, we then have to write a board exam, and we're either certified through the Canadian Association of Genetic Counselors and or the American Board of Genetic Counseling. Next slide. So what is our role exactly? So we have many different roles. There is the technical side, but there's also the coping part of dealing with difficult scenarios. And just to kind of give you guys a feel of where we can help in terms of the diagnostic process or in terms of being diagnosed with a rare disease. We can help people decide about genetic testing or screening if and when it's indicated. Talk about family planning. Oftentimes people will have questions. There's a particular disease in their family and they want to know what their risks are for having a child with that specific disease, what it is living with a genetic condition, helping people cope with the idea of caring for someone who has a genetic condition. Also being at risk, knowing that there is this genetic condition in the family, what is my personal risk, and so we help people dealing with those different types of emotions. And also, you know, we meet people in very specific moments of their lives. So we do try to help our patients to make connections to support services in their own particular community. Next slide. And so genetic counseling, again, is a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So that is our official title or official definition according to our association. Again, you know, genetic counseling doesn't mean that it has to be coming from a genetic counselor. Many physicians who order genetic testing can provide genetic counseling as well. Genetic counseling really is just helping people make informed consent about the testing, about the content, about the information. So your neurologist may have been able to provide that information beforehand as well. Except for genetic counselors, this is our role. This is the only focus of topic of conversation during our consultation. And I think one of the biggest misconceptions is that genetic counseling does not necessarily equal genetic testing. So a lot of people will think, well, I don't really want genetic testing, so what's the point of having genetic counseling? And vice versa. Some physicians will tend to think, well, genetic testing is not indicated for this particular disease, so there's no point in having genetic counseling. But for us, it really is about the communication and about the content information that people need to be able to make informed consent. Next slide. So when and how can I consult a genetic counselor? So we are part of a Canadian healthcare system. As I said, we're quite rare, but typically in traditional, we are found in a medical genetic department in the main university, hospital university centers. We are starting to broaden out into outskirts of the main cities. We can be found in research settings, also in different private clinical diagnostic labs, and there are starting to be some private clinics that are out there, as well as ministerial consultations as well. And so typically, the way to see us is to get a referral from a healthcare professional. And so sometimes the physician will offer it to you, depending on the services that are available. Again, for where you're located, in service of genetic counselors or the genetic services may not be easily accessible. But I think the one good thing that COVID came out of from all this is that the virtual consultations are becoming the norm. So even if someone is living quite far away, they may have access to genetic counseling services in the main city of their province. And so a physician may recommend meeting with a genetic counselor if you've been diagnosed or you're at risk of a genetic condition. This I will leave very broad. Genetic condition can be, we may have different specialties, meaning a person may be specialized in prenatal genetics. For others, we may be specialized in pediatric genetics, and for others, adult genetics, which can then further be divided into, for example, cardiac, oncology or cancer genetics, and for myself, my specialties in neurodegenerative diseases. If there's a family history of a genetic condition, some people may request having a genetic counseling session to further understand what their risks are. Oftentimes when a person gets diagnosed with a genetic condition, genetic counseling for the family members would be available. Other reasons that a genetic counselor may be indicated to meet with is if you're, for example, related to your partner, if you're first cousins, and you want to better understand what the risks are of having a child with this person that you're distantly related to. If a couple has a history of miscarriages, for example, typically we would see people after 3 or more miscarriages or for any causes of infertility, or if there's an ethnic background that may be eligible for populational screening. So these are very typical broad reasonings of why people would meet with a genetic counselor. And next slide. So the process with genetic testing, meeting with a genetic counselor may or may not equal or mean being prescribed a genetic test. So oftentimes the physician may have ordered the genetic test and they're being referred to a genetic counselor to be able to talk about the results and the implications for the person and for the family members. In those contexts, and in the context where we do offer genetic testing, our purpose is to provide the pre-counseling before receiving results. And for this, our goal is to help you understand how the information of the testing may be used, explore the decisions that may need to be made if testing confirms a genetic condition. So, we will put you in a scenario of what if a genetic comes out positive or negative and what that means for the person themselves and also for their family members. We typically, in the pre-counseling sessions, prepare the person to deal with results that may not be desired, whether that's positive, sometimes it's negative, and sometimes we fall into these gray zone results, and so those may be difficult to handle as well. For the most part, genetic testing is a blood test. Sometimes we can use saliva or a buccal swab or amniotic fluid in a prenatal scenario. And also very rarely we may request a skin biopsy, but that's quite rare. Next slide. So now just against the basic genetics so that we can better understand the next topics of genetics and ALS together. So this is basic genetics 101. These are concepts that we learned back in biology, but I'm just going to review them again so that we better understand, or we have the same meaning of what a mutation is, what a gene is. So our little stick man, that's us as human beings. Our bodies are made up of billions and billions of cells. And if we look into every single one of these cells, I don't know if you can see my little arrow here, but in every single cell, we have what's called our DNA. Our DNA contains every single bit of information that we need to be a human. How to grow, when to grow, how to move our muscles, how our hair grows, the color of our hair, the traits that we have. Our DNA is very, very, very long. The DNA can be divided into sections, and we call that a gene. And so the role of the gene is to tell the body what to do and how to do it and when to do it. With 20,000 genes, a lot of things are happening. If we look a little bit more closely into our DNA, now we're zooming in. We have what's called our DNA code. Our DNA is actually made up of 4 different letters. And these 4 different letters compose our code. So it's kind of almost like reading a book, right? If someone, a little child looks at a book and they're not able to read, all they see is a bunch of letters. But once you learn how to read, you realize all those letters are put there in specific areas, and it actually tells a story. And so the same concept with our DNA. If we zoom out a little bit more, our DNA is so compact, there's so much information, it gets compacted into chromosomes. And we actually have 23 pairs of chromosomes. The first 22 pairs are shared between men and women, and the last pair, the 23rd pair, is our sex chromosomes. So XX, you're a female, XY, you're a male. Now, if you look at our DNA code, our letters made up of here. Next slide. This is where we're going to go into a little bit more detail about our DNA code. Our DNA code needs to be almost perfect, meaning it can handle certain variations. Variations mean one letter has been modified for another letter. And Christiana, if you want to click on it, I don't know if you saw that, but this little GA here, one little letter can be modified. Sometimes those letters, that little variation can basically mean nothing, meaning that is the difference between having very blue eyes or very gray blue eyes. Sometimes it really is just a benign change. And other times, when we talk about genetic conditions, having that one letter be modified equals the gene not functioning properly and leading to a genetic condition. And we typically call that a mutation. New guidelines are calling it now pathogenic variants. And so depending on the terminology, but I will continue using the words mutation, which basically just means that there's been a modification to our DNA code. The DNA code is no longer what it should be. It's actually changing the function of the gene. And basically the role of the gene is to tell the body how to do it. And it typically does that in the form of a protein. And just to show, the next couple little clicks are going to be different types of mutations that can occur in our DNA code. So there could be little changes in one letter. That little X means a chunk of our DNA may have been removed, and we call that a deletion. Again, changes a function of the protein. Next little click. Sometimes what can happen is we can have add-ons. So if you see the last 3 letters, ACA, has been repeated. We can either call that duplication if it's been repeated a couple times. Sometimes it can be called a repeat expansion, when it's these typical repeats that should be seen together and has been repeated many times or too many times. All these different types of mutations can lead to a protein that doesn't function properly and can lead to a different impact in our body. Next slide. So all these genes in our body, all these genetic mutations, these are typically inherited. And so basically when mom and dad meet and the sperm and the woman's eggs meet, this is typically when these gene mutations are inherited to the next generation. There can be different types of modes of transmissions. For the purpose of today, for our conversation today, we're going to focus on the 2 major types of transmissions: autosomal dominant and autosomal recessive. Autosomal dominant basically means autosomal means it is found in a gene that both men and women share. Dominant, I'll just give you the punchline right now, basically means if you have a genetic mutation, each one of your children or future generation has a 50% risk of having the same gene mutation. The reason for that, I'll go into a little bit more details now. Next click. So each one of us has 2 copies of every gene. I did say we had 20,000, about 20,000 genes in every single one of our cells. Reality is we always have 2 copies. And 1 copy comes from mom, the other copy comes from dad. It's as if we have a backup for every gene that we have. In an autosomal dominant genetic condition, one copy of the gene is working just fine, and the other copy of the gene is not working. And that is basically indicated by the pink part of this copy of the gene here. And pink being affected, and in this case scenario, the mom is affected, but when we're talking about autosomal, both men and women can be affected. So for the purpose of this presentation, the black gene means the gene is healthy, it's working, and the pink one means the gene has a mutation, so it's not working properly. At the moment of transmission, we give half of our information to our children, and our partner gives the other half. So in this case, the gentleman here gave one copy of the gene, and now the second copy is going to come from, or he can give the other one. Okay, so basically, we each have two copies, one gets transmitted or the other one, and then our partner gives the other half. Okay, so in this case, this person here is giving one copy that's unaffected, and now this person has transmitted another copy with the gene that is affected. So this is where the 50-50 chance is coming in from. Complete probability, we have absolutely no control or no choice into which genes are being transmitted. Don't forget, this is happening 20,000 times at every single conception. Okay. And then next little click. And then the second mode of transmission, we call this autosomal recessive. This is a little different. So the difference with autosomal dominant is that when one copy works and the other copy doesn't work, the person is affected. In a recessive transmission, a person can have one copy not working and one copy working, and this person is considered a carrier only. That means they will not develop the disease, they will not show symptoms related to it, they're simply just carriers. In order for a child to be affected, both mom and dad need to be carriers for the exact same gene in their genome, right? So we have 20,000, so that means both mom and dad need to be carriers to be able to have an affected child. And when that occurs, the risks for each conception or every child that they have is a risk of 1 in 4 of also being affected or of being affected. And again, it's just the way which gene gets transmitted at the moment of conception. And so there's a 1 in 2 chance that their child will also be carriers, or 1 in 4 chance that their child is completely unaffected and not carriers. For the purpose of ALS and the genetic forms of ALS, we don't see this mode of transmission very often, but it can occur. But the more typical mode of transmission is a dominant transmission for ALS and genetics. Next slide. There we go.
Thank you, Nancy. I'll take over for the presentation for a little bit. We wanted to start off by really going into detail as to the role of the genetic counselor and why genetic counseling is so important, and then lay that foundation on Genetics 101 so that we can start off on a good foot of understanding for the next few slides. But we're obviously all joining the call today because we have an interest in, we're affected by, or we're caring for somebody living with ALS. And so let's dive into some of the genetics specifically for ALS. You may have seen a similar graph to this or heard about the two terms called familial and sporadic. For the purpose of the presentation today, I'm going to keep it really simple and leave it as familial or sporadic, but there are different terms out there depending on which country you're in. Some people may call it hereditary ALS as opposed to familial. Sporadic ALS may be called isolated ALS. And we are also moving away from using these two terms because we're starting to recognize that it's not quite accurate to describe the population in this way. But you will hear me use the terms familial ALS and sporadic ALS in the presentation today for simplicity. So it's important to note that familial ALS and sporadic ALS are clinically indistinguishable. In familial ALS, there is a family history of the disease. There's a family history of ALS or other related disorders. And in sporadic ALS, it's an isolated case. There's no family history. But when a patient comes to the ALS clinic in terms of symptoms, how the disease progresses, etc., they're indistinguishable in the sense that we can't clinically do anything other than a genetic test to determine if the ALS is genetic or has an isolated cause. So these patients look the same when they come to clinic, but some might have a family history and some might not. There are still cases of familial ALS, so again, where there is a family history of the disease, that have an unknown cause or an unknown mutation. So if we look at this pie chart on the right side, that purple portion of the pie represents unknown. So even though these families have a clear family history of the disease, we have not yet identified a genetic cause. On the sporadic side of things, there are some cases of sporadic ALS that do have a genetic cause. So these same colors in both pie charts, you don't need to know what these genes mean or what these words mean here at this point, but they overlap. So the same genetic mutations, which Nancy just described what that is, are found in both isolated cases with no family history and cases with family history. And so because of this, we can start to think of ALS more as a spectrum, where previously we used to think as familial ALS with those with a very clear family history. This is called a pedigree. The squares are men, the circles are women, and the dark colored squares or circles are those affected by the disease. And so you can see ALS through each of these generations extended here. It's very clear. It's known to these families that ALS or related disorders are in the family. But when we think of ALS as a spectrum, we would have these familial or hereditary families on one end of the spectrum, and then the very distinct sporadic cases where there is no family history, not even a hint, all the way on the other end of the spectrum. But what we're starting to recognize as we understand more and more about genetics and ALS is that there might be two other cases here in the middle. The first could be families with what we call reduced penetrance. Penetrance means the probability that you will develop the disease if you have the gene defect or the genetic mutation. In some ALS mutations, associated mutations, penetrance is close to 100%. If you have the mutation, you will develop the disease. However, there are many ALS-associated mutations where penetrance is what we call reduced. So even 90% or 80% reduction of penetrance, there is a risk that you can have the mutation and not develop the disease. And this causes kind of gaps in the family tree. So when we look at this family tree again, we see some scattering of distantly related individuals where there's gaps in the family tree. So this individual is affected, but neither of their parents were affected by ALS, nor were the grandparents. Yet, if you look further on the family tree, there are other family members who are affected. So this indicates that there could be a genetic cause at play, but unless you're looking at the entire family and a broad view of the family, you could easily miss this. Then there are also individuals who have a mutation confirmed to be causing their ALS, but have no family history of ALS or related disorders at all. So we're starting to think of this more as the spectrum of a wide variety of genetic implications. And so going back to just genetics and ALS, genetics has largely fueled our understanding of ALS as a disease as a whole. So the first mutation associated with causing ALS, the SOD1 mutation, was first discovered in 1993. And since then, we've discovered a number of other mutations associated with either causing or increasing risk of developing ALS. And this has been quite exponential growth over time. It seems like every year we're now discovering a new mutation associated with ALS. And if you're listening into the call today and you don't have a family history of ALS, or you've had genetic testing and you don't have a genetic cause of ALS, how does this affect you potentially? Well, we want to develop therapies and treatments to treat ALS. And the more we can understand about the genetic causes of ALS, the more we're going to understand about the disease as a whole and then be able to develop therapies to target that. The reason being is that all of these genes associated with causing or increasing risk when they're mutated of getting ALS, the underlying biological pathways are also connected in the way that they contribute to motor neuron health. And so we know in ALS, ALS that the motor neurons are dying, and that's what causes the disease. And so the more we can learn about these underlying biological pathways that contribute to motor neuron health, the better we can develop targets, drug targets for those pathways for ALS as a whole. So genetics helps us understand all of ALS. It's also important to note that globally, there's variation of genetic mutations. So we live in Canada, we live in a very ethnically diverse country, and so the incidence of some of these mutations is going to vary worldwide. For example, we'll talk more about the C9orf72 mutation in a moment. This is a very common mutation in European populations. However, in this publication, it showed that less than 2% of populations in Asia are affected by the C9orf72 mutation, whereas that can be around 15%, including familial cases in European populations. So that's a big difference, and we need to get better in terms of our basic research and our gene discovery in including underrepresented populations in both clinical trials and studies to better understand the gene diversity globally. So when we look at ALS mutations, frequency of ALS mutations varies depending on whether we're going to classify someone as having familial ALS or sporadic ALS. So again, I'm using these terms because it's simple for the purpose of the presentation, but if we recall a few slides earlier, sporadic and familial are a very arbitrary distinction because they're clinically indistinguishable. That doesn't truly reflect genetic cause. So I'm not going to look at these numbers in detail, but if you see in the column under familial ALS, these are just the incidences of these 5 mutations listed here in familial cases of ALS. These 5 mutations that I've put in the table, there are more than 40 genes at this point that are associated with causing or increasing risk of getting ALS. These 5 that I've included here in the table are those for which therapies are currently being developed, so just a snapshot. So in familial ALS, those 5 genes will account for roughly 70% of all familial or hereditary ALS cases. When we look at the sporadic ALS population, so the right side of that table, numbers are a lot smaller. It seems like it's not as common to have a mutation. If you have no family history of the disease, you have a seemingly isolated or sporadic case of ALS. However, that incidence is still there, 2 to 4% for SOD1. As I mentioned, C9orf72 is quite prevalent in European populations and is known to account for 7 to 10% of sporadic cases of ALS, so having no family history at all. And then these other 3 have a rather low incidence. But when you combine all of these together, you get potentially 11 to 16%. This is based on one review article that I pulled these ranges from. It can vary depending on which study you look at. But you can get this range of 11 to 16% of sporadic ALS cases having a known genetic etiology to their disease for which therapies are being developed. And so if we combine our 5 to 10%, which is roughly what we say are ALS patients who have a family history of the disease, with this 11 to 16% who have a monogenetic etiology, so they have an isolated case of ALS, there's no family history, but they have a confirmed genetic cause to their disease, we get to a total of roughly 10 to 25% of all ALS cases having a monogenetic etiology, so there's one gene mutation that's responsible for causing their ALS for which therapies are being developed. So that's in stark contrast to a couple of years ago. If you would listen to a scientific presentation or read about ALS, it's often quoted that 5 to 10% of ALS cases are familial in nature and they have a family history, and the rest are sporadic. This is why, again, we're starting to evolve our thinking now in that more of the disease might have a genetic cause than we previously thought. And if we're not testing, then we don't know that. And so this was going to go into later in the presentation when we talk about genetic testing for ALS. So I mentioned that therapies are being developed. That's, the ultimate goal for ALS is to find a therapy that is effective at treating ALS. And so there are a number of therapies that are specifically targeting these various gene mutations associated with causing ALS. I'm not going to talk about any one of these therapies specifically today. I'm more going to talk about what type of therapies these are that are being developed and how they target the gene mutations. If you have any specific questions, though, we're happy to address those in the Q&A. So the first one I'll talk about is antisense oligonucleotides. It's a big mouthful, a big long word. We call them ASOs for short. They're short pieces of synthetic DNA. They're not true DNA. They don't come from human. It's made in the lab. But as Nancy mentioned, DNA code are these short little sections of those DNA units that tell the body to do something. The goal of these short synthetic pieces of DNA are to reduce, restore, or modify protein function. So she also went through the different ways in which a change in our DNA can cause a genetic disorder by either changing one of the DNA units, deleting part of the DNA units, or having a repeat expansion, so DNA that's not supposed to be there. These short synthetic pieces of DNA go and bind to our DNA and try to prevent that, that function, that mutation, that defect from happening. So they reduce, restore, or modify protein function. There are several approved antisense oligonucleotides for other diseases. The example that people might be most familiar with is Spinraza for spinal muscular atrophy, which was approved about 5 years ago now. These cannot cross the blood-brain barrier, so they do need to be injected intrathecally via lumbar puncture. So we're going to do a very simple example. We haven't talked about these gene mutations in detail because there are so many of them, and they are very, they all are involved in different pathways, but I am going to use the SOD1 mutation as an illustrative example for the next few slides. So what happens in SOD1 ALS is you have your normal DNA that forms a normal protein. That's this bad drawing here on the slide. The SOD1 protein has a normal function in our body involved in antioxidants or reduction of antioxidants. And so it has a normal function. There's a lot of other antioxidant pathways in our body. This is just one of them. And so let's say that this is what the protein normally looks like. When we have a mutation, so we have a single DNA unit change in the SOD1 gene, that single DNA unit change results in a different protein. So it's still that SOD1 protein, but it doesn't look the same. It's not folded correctly. It's what we call misfolded. And then these misfolded proteins clump together and stick to each other because they're not the right shape. And it's accumulation of these misfolded SOD1 proteins that causes ALS in individuals who have a mutated SOD1 gene. Again, we haven't gone into detail about all of the different mutations associated with ALS and their functions because there are so many of them. I've used the SOD1 example today just because it's a simple example to explain. You have a mutation, you get a different formed protein, and it is that misfolded protein accumulating in the body that is causing the disease. So when using antisense oligonucleotides, that little short piece of synthetic DNA, this little piece down here, comes and binds to the mutated DNA, just blocks it, sticks to it, and it blocks it. And so in that case, we don't get any more of this mutated misfolded protein. And if we have no more misfolded protein, then those misfolded protein clumps can't form anymore. And so this is an example of how an antisense oligonucleotide would reduce protein function of the misfolded protein that is causing ALS. Another type of therapy that can be used to target genetic diseases is antibody therapy. So antibodies are proteins that are used by the immune system to identify and neutralize foreign bodies. They act as like a little flag. They stick to foreign bodies like virus, bacteria, and they signal the immune system that like, hey, this thing is not supposed to be here. Can you please get rid of it? They can be synthetically produced, so they can be produced in a lab to target a specific protein or virus or bacteria, etc. And therapeutically, they can be used to utilize the natural immune system in combating disease. So how do they do that? We're again going to use the SOD1 example because it's a simple illustration. So again, we have our DNA, the SOD1 gene. There's a single DNA unit change, a mutation in the SOD1 gene that's causing ALS. It causes protein that's misfolded. It's not formed correctly, and these misfolded proteins clump together to cause ALS. In this case, we're not targeting the DNA as we were with antisense oligonucleotides. This antibody, and this is their shape, comes in and sticks to the misfolded protein. And so then what this does is it flags to the immune system that this protein's not supposed to be here. And just like your immune system would eliminate bacteria or virus, they're going to come and your immune system cells are going to eliminate the misfolded protein. The final type of therapeutic strategy that can be used to combat genetic disorders is gene therapy. Gene therapy can be extremely complex, so I've tried to make it as simple as possible today. It replaces or corrects a faulty gene. It most commonly uses viral vectors to introduce the correct gene. So in this case, we have a viral vector. It's a virus that's benign to humans. One of the most common types is an adeno-associated virus, AAV. The virus, what it does when it gets into the body is it replicates itself. So what we do in gene therapy is we take the healthy gene, this green portion of DNA here, we insert it into the viral vector, which is then injected into the humans. And when the virus replicates itself, it's also going to replicate that healthy gene. So it is providing the healthy gene to the human when there's a genetic defect. These are very, very novel therapies, and there are not many approved. I believe at last count there was 7, if I'm not mistaken. The example that people might be most familiar with is Zolgensma, again, for spinal muscular atrophy. So how does this work with SOD1? It's our example again. We would do the injection of a gene therapy into a human. These are usually one and done injections for gene therapies. And what you would have is corrected DNA introduced into the body. So gene therapy is not a perfect fix because you still have your mutated gene that's present. So, but it does introduce the correct and healthy gene to produce healthy protein as opposed to that misfolded protein. We do not have any gene therapies in clinical trial for ALS at this moment. There are a couple of companies that are in the early stages of development of gene therapies, though, which is exciting. So in summary, there are 3 main strategies for genetically targeted therapies for ALS. Could have antisense oligonucleotides, which interrupt the mutated gene, antibodies, which flag the end product, which is protein, for destruction by the body, and gene therapy, which is still very experimental at this stage, but corrects the gene. And so I'm going to hand it back over to Nancy now, but we've taken you through some basics of genetics, a little bit about ALS and genetics and what that looks like at this point. ALS and genetics, again, genetics is going to help us understand all of ALS. And so if we can make therapies that target the genetic forms of the disease, and we can better understand how to treat the genetic forms of the disease, it's going to contribute to our understanding of the disease as a whole. And so we're going to move into genetic testing now, and I'm going to hand it back to Nancy.
Thanks, Chris. Okay, so now we'll be a little bit more specific with what does it mean to have a genetic testing for someone living with ALS. So typically this is a genetic counseling session that would last about 1 hour. In the past, we were seeing patients in person, but now it's looking more, we're doing some more virtually, sometimes by phone. We are taking a detailed family history for the exact reasons that Christiana had mentioned before. We're trying to evaluate, could there be any possibility of any signs of ALS in the remaining family history to kind of further understand whether this is sporadic or whether this is familial. We're going to personal medical history, and of course, all this remains confidential as like any other medical appointment. So our role here is to talk a little bit more into detail about what are the risks for the person individually. What is the risk of identifying the gene in the person themselves? If we do find the gene, what is the inheritance pattern? So what are the risks for other family members? If we do go ahead with genetic testing, we would then talk a little bit more into detail which one would be recommended. Do we do a full panel of genes, or do we just limit the genes related to isolated ALS, which is what we're going to speak about a little bit more detail. And before doing genetic testing, obviously we want informed consent. Informed consent isn't just to sign the paper, but it really is to talk about in detail what it means should we find the gene, whether the results become positive, meaning we identify the gene, or negative if we don't identify the gene. Next slide. So some of the discussions that we have before doing genetic testing. In the perfect scenario for any type of genetic testing that we do for any type of disease, we always want to be offering genetic testing for the first time with the person that is diagnosed with the disease. And in this case, it's ALS. And so we consider this diagnostic testing. Okay, it's still genetic testing, but the person has a clinical diagnosis of ALS or suspected clinical diagnosis of ALS, and we're offering genetic testing to see if we can further identify the cause of their diagnosis. And so in a case where we're talking about isolated ALS, what is the likelihood of identifying genetic change? Of course, depending on the family history, we may kind of give our suspicions whether we think there would be a low likelihood of identifying gene or a high likelihood depending on the family history. We would then talk about the implications for family members and future generations. How is the person going to handle having that discussion with their children, with their brothers and sisters, and possibly their cousins that they may have not spoken to in many years. Also, other considerations before doing genetic testing are the emotions that may come out from a positive or negative result. And our main reasoning for offering genetic testing, particularly in the isolated ALS, is for clinical trials. So if you were to meet with a genetic counselor, the possibility of a clinical trial would be discussed, but for any further information, we would refer you to the appropriate person to further discuss in details what the trials would look like. Next slide. So whenever we do genetic testing, again, once a person decides whether they want testing or not, they at all times have the right to refuse the possibility of doing genetic testing. Should they accept it, there's always 3 possible results that can come out of any genetic test results. Whether we're talking about ALS, whether we're talking about cancer genetics, or even cardiac genetics. So the more common result that we would get is negative, meaning we've analyzed all the genes that we know to be related, and we didn't find anything. Meaning, we read our DNA of that particular gene, and no mutation was identified. We always have to understand that whenever we say something is negative in genetics, we always need to be aware of the possibility that negative for us in genetics is kind of a false negative, okay? Meaning that we're giving a negative result based on today's information. It could be that the person we tested is negative because they just don't have a genetic cause. Okay? There's no genetic reasoning for having developed ALS. The majority of cases when we're talking about isolated ALS, it really just happens sporadically. Okay? There is no one gene. So for the majority of the time, we can say to the person that they have a negative result because there is no genetic cause. However, we can't be totally reassured because it does remain possible that the person just has a gene, just not the gene that we tested for. Right? We can only test for information that we are aware of. So maybe that person carries a gene that will be identified in the future, but as of yet, we can't test for that. Or it's quite possible that person may have one of the genes that we tested for. Just our technology, based on today's technology, couldn't pick up the more rare type of mutations. Okay, so this happens for all of our genetic tests. possibilities or results. Genetics is evolving very quickly and very rapidly. So depending on the family history, we may determine, or we may ask the family or the patient to come back in 3 or 5 years and see whether new testing has been made available or whether technology has changed. So, even with a negative result, you may get personal recommendations. For some people, we may do further testing for different types of diseases that may look similar to ALS. Okay, so this is where it becomes a little bit more on the medical side, working with the physician. There are some people where it's a clear-cut diagnosis of ALS, and for other people where the symptoms have just begun and symptoms may look like other conditions, the physician may use a genetic test to determine whether the person has another condition that may have symptoms similar to ALS. When results are negative in a person with ALS, we do no further testing for the remaining family members. Okay? Because if that person tested negative, we're not going to find anything new in their children or in their brothers or sisters. The second result is uncertain, meaning we call this a variant of unknown significance. And so basically, our technology is there. Okay, we are able to read our DNA, no problem. This is very different compared to 10 years ago. 10 years ago, we had a limitation in technology. We could not read our DNA, our full DNA. We can only read our 1 gene per gene. We've had a new technology that came out almost about 10 years ago, and we're able to read our DNA, no problem. What can come out of it, though, is actually we identify too many variants. And sometimes there's so many variants that we're just not able to classify whether the variant is benign, meaning it has absolutely no impact on the gene function, or that the variant is actually a mutation and that it will lead to the gene to not function. So an inconclusive result, or a VUS, basically means we've identified a change, we just don't have the data to classify it as benign or a mutation. And in science or in medicine, we will never make a diagnosis based on one person, right? So we want to wait for research to kind of evolve, and so that we can have more information and more data on that particular variant. Sometimes we may let the person know, call us back in about 3 or 5 years. We'll see if there's any updates, if there's any further information on that particular variant. Sometimes a variant may actually look quite interesting in the sense of we may think this is more important than what the lab is classifying it as. So we may ask to test family members if possible. And sometimes we'll look at the variant, we'll look at the gene, and we'll say, don't worry about this. This is looking negative. We're not going to do anything further based on this. So the variant needs to be looked at specifically, and also the person's health condition needs to be looked at, and we kind of correlate that together. And the third possible result that can come out of genetic testing is positive. That just basically means a mutation in a gene has been identified, and now we are confirming that the person's clinical diagnosis is related or caused by this particular gene. Now we are able to provide genetic counseling for the patient and let them know what the gene is. What clinical description do we typically see with this particular gene? What is the mode of transmission? What are the risks to family members? We have to remember, whenever we're doing genetic testing, we have 20,000 genes, okay? So the importance of doing genetic counseling is that every gene has a different story. Every mutation almost has a different story. So this is not kind of like our cholesterol testing where you can compare your cholesterol numbers with your neighbor, or your blood pressure numbers, and everyone understands what that number is. When it comes to genetics, the content and the information that you receive may sound and look very different compared to someone else, because it's just not the same gene and it's not the same information. And when we do find a gene mutation, now we're able to offer genetic testing for family members who are interested in having that information for themselves. Next slide. So what about that person who comes into clinic who's unaffected, they are healthy, but they have a family member with ALS? We get many requests for these types. So basically, someone just wants to understand what their risks are. in terms of ALS regarding their family history. So if the person has no symptoms, in a perfect scenario, we want to test the person who has ALS. Okay, so if someone comes to us and says, my dad or my mom has ALS, first thing we'll ask is, are they alive? If so, we'll test that affected person with ALS. If the affected person is negative or positive, then we go on and we have that risk counseling session with the unaffected family member. If the person comes to us is unaffected and informs us that their gene has been identified in the family, then we call it predictive testing. Predictive testing is very different compared to a clinical diagnostic testing. The reason why predictive testing is a little different for neurodegenerative diseases is simply because this is neurodegenerative disease. At the moment, there's no prevention that we can offer you if that person wants to have genetic testing to delay or to stop the onset of symptoms of a condition of ALS. And when the diagnosis does happen for ALS, there may not be an effective treatment to help with the diagnosis. And so predictive testing is a very personal choice. And the first time we were able to offer predictive testing was with a different condition that's completely unrelated. It's called Huntington's disease, but it was a first disease, genetic disease, where we were able to offer testing in unaffected family members in a predictive context. There was a lot of ethics back then about whether we should or should not be offering predictive testing in unaffected family members. And what they decided was that there would be a protocol established. Protocol is quite lengthy. I'm not going to go into too much detail at this point, but the purpose of the protocol was to ensure that the person was well surrounded and had proper services and support, because the implications of any genetic test results were much more psychological and emotional. Okay, this was not if someone is seeking predictive testing when a gene is already identified in the family, there will be very little medical implications when we give results. The immediate implications are much more emotional, psychological, so we want to ensure that the person is well surrounded and has services and support that they need before doing genetic testing. So these are long conversations that I would typically have when a gene is identified in the family and family members want to know. Not everyone wants to have testing, but some people just want to have information as well. And so it's perfectly okay to seek genetic counseling in this context. Just recognize that it's a process. There's some people who will come to me and say, I absolutely want to have genetic testing. There's other people who will come and say, I want to know what's going on. I want to better understand, but not necessarily do the genetic test. And there's other people who will never come and just don't want to know. And every choice is perfectly fine, as long as everyone understands what their options are. People who do come and see us will be coming a lot for life planning. Whether, do I have more children? Do I not have children? Do I take my retirement early? Do I not retire? Some people come in for financial reasons. Other people just have the desire to know, and will do some things a little differently compared to what they're doing, to how they're living to today's lifestyle. And so every choice is personal, as long as a person is very well informed as to what the implications are. We do need to take insurance into consideration. However, this has been less of a discussion in the past 2 years. There is now a Genetic Non-Discrimination Act that has been in law here in Canada for the past 2 years. Basically, that law says that whenever you sign a contract, any contract, whether it's work-related, whether it's insurance-related, they are not allowed to ask you for your genetic test results. They are allowed to ask you about your personal medical history, as they have always been. They are allowed to ask you about your family history, and based on your family history, they can determine risks based on that. But as of yet, with this law, they are not allowed to ask you for a copy of your results. Some people may choose to do, or now I think where clinical trials are headed is also doing clinical trials for pre-symptomatic gene carriers. We're not there yet. It's in the pipeline, but that may be a different motivation for people wanting to come in and have genetic testing before the onset of symptoms begin of ALS. So predictive testing is a very, very heavy topic, but interesting topic as well, but we'll stop there. Next slide, please. So what are the genes that we are testing for in ALS? We will give a little bit. So overall, the C9 or ORF72 gene, basically I'll just call it the C9 gene for short, is the most common genetic change that is associated to ALS. I think Christiana gave a little bit more details in the table before, but basically it's found in 40% of hereditary cases and about 7 to 8% of sporadic cases, predominantly in European populations. The second gene that is commonly found is a SOD1 gene, and is identified in about 20% of hereditary cases and 3% of sporadic cases. The next gene that we find or can find is the FUS gene. This one has been associated with juvenile ALS. And when I say juvenile, we're talking about ALS being diagnosed in the 20s, sometimes 30s. Okay? We can see a very varied description or clinical presentation of each one of these genes, but FUS tends to be a little bit more on the earlier onset, whereas C9 can be a little bit on the later onset, but the risks tend to start to increase after age 35, 40, as well as SOD1. SOD1 can have different onsets depending on the mutation. And the last gene is Ataxin-2. So with Ataxin-2 is a little different compared to the other ones. The other ones, if we identify the gene, we can actually say that the gene is related or caused or is causing the ALS in that person, which is very rare, right? Like most people want to know why did I develop ALS? When we find the gene, we're actually able to say this gene contributed as a major risk factor for the development of ALS. Ataxin-2 is a risk factor gene, meaning you have the gene, it's not 100% you will develop it, but the risks are just slightly elevated. It's a relatively new gene that we've recently added onto our panel. Little information available as to what that means when we do identify it, but this is the type of gene where we are offering it because there is a clinical trial available, but we wouldn't necessarily offer it to unaffected family members just because of the information that we have available to give as to what their lifetime risk factor is, or the lifetime risks of developing ALS is not well documented as of yet. And again, there are many other genes that are associated to ALS and dementia, and TDP43 is just one of those. Sorry. And next slide, please. So in our clinic at the Montreal Neurological Hospital, the flow or the way we've decided to offer genetic testing to every one of our patients with ALS is basically everyone who has a new diagnosis of ALS is offered genetic testing. A person may refuse, and they may accept. Whether they refuse or accept, it will not change their regular follow-ups or have anything else. Everything else will be maintained and available to them. What will determine what type of testing we do will be based on their family history. So if we look on the left side, if the person has an isolated type of ALS, meaning we do not see any obvious family members with ALS, we go ahead and test for the C9orf72. Same thing with the family history. If there is a family history of ALS and or a specific type of dementia called frontotemporal dementia, we will still go ahead and do genetic testing for C9orf72 just because it's the most common gene that we find in both the isolated forms of ALS and the familial forms. So if we do identify the gene, we stop there, we found the cause, and it stops there. If we did not identify the C9 or 72 gene, then we go ahead and we order further testing. When the person's coming, one has ALS in the isolated form, basically the only genes we would test for are the genes that are related to clinical trials. So SOD1, FUS, and Ataxin-2. We would not go ahead and order the other genes because it's not clinically indicated. Okay, the clinical indication to do testing for these particular genes really is in the context of clinical trials. Otherwise, if the person has a family history of ALS, ALS is a rare disease. So when you have 2 or 3 family members with ALS, there must be something causing this. And so there must be a gene related to the cause of the ALS in that particular family. So we go all out. We do all the genes that are known to be related to ALS. In this category, we also will order this panel of testing when someone is very early onset. They develop ALS in the 20s or 30s, even if there's no family history. There may be exceptions to these rules sometimes, but again, the clinical description and the family history is all taken into consideration on which panel of testing we would do. Next slide. There we go.
Thanks, Nancy. So now I'm going to go into a little bit more detail about genetic testing in Canada. So Nancy just went through our flowchart of testing as the neuro, but what is the situation elsewhere in Canada? So some of the next slides that I'm going to show you are from a recent publication that we had last fall from a study assessing genetic testing practices in Canada. And so just a quick disclosure that this work was funded by Biogen. So we wanted to assess what is going on in terms of genetic testing practices across the country, because we can't start to improve access to genetic testing and counseling, for which there is an increased motivation now for patients to seek, given all of these clinical trials in development. We can't start to improve that unless we understand what's currently going on. So there are about 30 ALS clinics that we identified across Canada. Many of them are very large, multidisciplinary, large academic centers, but there's a few smaller ALS clinics as well that do provide prospective care to patients in some of the smaller regions. We had 27 of these clinics participate in our survey, and then we conducted interviews with clinicians, 25 out of those 27 clinics. So in terms of familial ALS, so patients with a family history of ALS, the majority of clinics are routinely offering genetic testing to patients who have a family history of the disease. There's a small number of patients when this translates into clinics, this translates to, I believe, 2 clinics. In our sample size that do not routinely offer genetic testing to patients who have a family history of the disease for a variety of reasons. They could feel that patients are declining the testing, a lack of access to genetic counseling is a major barrier in one of those clinics, a perceived lack of implication for the treatment plan, or that ALS genetics are poorly understood and they don't have that support from medical genetics or genetic specialists to help them offer that testing. And I should mention, backtrack, this is from a study conducted 2 years ago, so in 2020. In terms of sporadic ALS or isolated cases, at the time that this study was performed, 1/3 of clinics were routinely offering genetic testing to patients with sporadic ALS. So this is a good start, but it's still not where we should be in terms of having broader access to all people living with ALS. And the barriers to testing sporadic cases of ALS were predominantly unclear pathway to request testing and to have it approved. So in that particular clinic or province, paperwork, approvals needed could be the barrier, which it was unclear how to get that testing ordered and approved for people who don't have a family history of the disease, or again, a perceived inadequate implications for treatment plan. In terms of access to genetic counseling, 2/3 of the clinics indicated that they did have access to a genetic counselor. However, that did leave 1/3 of the clinics having no access to a genetic counselor for their patients. The average wait time to see a genetic counselor for a symptomatic ALS patient in Canada was reported being around 10 months. And so that's much too long, and identified another area where we needed to work on helping to reduce those wait times. If neurologists were able or comfortable to do part of the genetic counseling themselves so that patients didn't have to wait as long, etc. All of this leading to what is the relative ease of access to genetic counseling and testing for patients living with ALS in the Canadian provinces. When we performed this landscape assessment 2 years ago, this was kind of like the lay of the land. This is a very rudimentary red, yellow, green traffic light system and way of illustrating this, but this is a good way of summarizing those results. So there were some provinces where access is really challenging. Potentially patients weren't being offered genetic testing at all, and some provinces had an easier access. So fast forward to today. So this is information that's current. A lot of those traffic lights have fortunately changed. So I'll just toggle back and forth between the two. I'll go through some of those changes, those improvements that we've seen in the last 2 years. We're still struggling in some provinces with access to genetic testing, but hopefully, I'd like to convey that the clinicians in those provinces are working very hard to help improve that access. So we've started to do a 2-year review. So again, we first assessed genetic testing practices in March of 2020. And so then as of today, there's been much improvement. But what exactly has that improvement been? So we've just sent out a survey to these same clinics. Just this last week. So this is like hot off the press data. We're still waiting for responses, but 81% of clinics who have responded so far have said yes, they have changed their genetic testing practices for ALS in the last 2 years. And some of those changes have been that testing is now offered to isolated or sporadic cases of ALS, where previously they weren't offering genetic testing to everyone. In some cases, more genes are being tested. In the last 2 years, we've had clinical trials start for both the FUS and the Ataxin-2 mutations. And so some clinics have added those genes to their panel of genes that they order. Some clinics now have access to a broader ALS gene panel. Previously, maybe they only had SOD1 and C9, even for cases where there's a family history, and potentially now have access to a broader panel. And some clinics have noted improved relationships with their genetic specialists, so genetic counselors and geneticists, to be able to support patients in that decision-making process and interpretation of the results. So some specific province by province wins and over the last 2 years. In the Maritime provinces, genetic testing workflow was established between the ALS clinics and the Maritime Medical Genetics Service, where all patients can now have access to genetic testing and should be offered by their neurologist in Nova Scotia, New Brunswick, and PEI. In Saskatchewan, as of September 2021, so very recent, genetic testing was approved in that province for all patients living with ALS. So again, no longer requirement to have a family history in order to get access to genetic testing. In Ontario, one of the major barriers remains that when a test needs to go out of the province and all of the commercial genetic testing labs are located in the United States, that individual request needs to have Ministry of Health approval. So it's a big paperwork burden, and it's not clear if the Ministry of Health is consistently approving requests for individuals who have isolated or sporadic ALS. However, C9orf72 testing is now available in the province of Ontario at a lab in the province of Ontario. So that alleviates that barrier for at least the C9orf72 gene, which, as we've highlighted a couple of times, is the most common mutation associated with ALS. There is also a sponsored testing program. What that means is it's a no-cost genetic testing program. It's available through a company called Invitae. It does need to be ordered by a health professional. However, it does not include C9orf72. So far, we haven't seen a huge uptake in use of this program because it doesn't include the most common mutation associated with ALS, but could be potentially an option for some clinics who are having trouble accessing testing. Globally, there's also a movement towards improving access to genetic testing for people living with ALS. The International Alliance of ALS-MND Associations updated their fundamental rights for people living with ALS-MND last year. In addition to all of the other things that the statement says, it now includes a statement that says people living with ALS-MND have the right to have access upon diagnosis to up-to-date education about clinical genetics and ALS, genetic counseling, genetic testing, safeguards against genetic discrimination, and subject to education and counseling. Blood relatives should be given that same access. This is a very aspirational statement, but we're starting to move the needle in terms of globally recognizing that there needs to be a broader offering of genetic testing to people living with ALS. And so there is also a group of international clinicians who have gotten together on the same topic. And so we published this paper a few weeks ago. It is published open access, and so anybody can go access it. You don't need to pay to read the paper. Again, mobilizing and calling to action that genetic testing should be offered to everyone who has a diagnosis of ALS. And so in summary, there is a significant genetic component to ALS, all of ALS, not necessarily just restricted to those with a family history. There are specific therapies that are being developed for ALS that have a known genetic cause. Access to genetic counseling and testing is not consistent across Canada. We've made great headway in the last 2 years. There's still a lot of work to be done, but it's very promising in that change has happened. A genetic counselor can help you determine if genetic testing is right for you and your family. If you do not have access to a genetic counselor, which some clinics do not have a genetic counselor at their institution or hospital, your neurologist may be able to help you make this decision. Some neurologists are very comfortable with the genetic counseling process and would prefer to handle that themselves with their patients. And if you've not been offered genetic testing, ask your neurologist if this might be an option for you. I just want to end with some additional resources beyond the presentation today. The International Alliance of ALS-MND Associations put together a series of webinars this past fall, which are all archived on their website. There is one on Introduction to ALS-MND Genetics, a second one on genetic counseling and testing, and a final one on ethical considerations for genetic testing in ALS. Because these were put on by the Alliance, these took a more global view, so not Canadian specific, but the speakers were all excellent, and all of the concepts that we covered today are also covered in those webinars. We're also working on some infographics to accompany those webinars, so written material. It's just a sneak peek that I've put on the right there. And finally, as I said, obviously your neurologist is your first point of care in a patient's journey of living with ALS. If there's specific questions about the presentation today or anything we talked about, I'm also happy for patients to send me an email and hopefully can direct them to the appropriate resources. So I've put my email below. And with that, I think we'll take some questions, and I'm going to try to figure out how to stop sharing my screen.
Thank you so much, Nancy and Christiana, for that comprehensive overview of ALS and genetics. I know for me personally, there was a lot of really good takeaways, such as the 3 therapies that are available, the ASOs, the antibody therapy, and the gene therapy. And Nancy, I found it really intriguing when you were talking about the Genetic Non-Discrimination Act and how that comes into play, because I think that that's a huge barrier for a lot of people. And it's so great to see the progress that you've made. Like, I want to applaud you both and the associations and the alliances that you're working with, because you're really working towards increasing equitable access for people to have the testing and to have access for genetic counseling. So thank you both so much. So I know, Melissa, you're going to go through the questions here. For those of you that are still with us, please do type your questions in the chat box. Just for some of you that are registered clients here in Ontario, I want to let you know that we are sending you a monthly newsletter. So this is the first webinar as part of a community services webinar series. So stay tuned for more information on some more upcoming webinars. And I'd also like to let you know that we have recently launched our Walk to End ALS webpage. So if you go to our website, you can go to the walk page and you can register yourself and get a head start on joining the walk. So Melissa, I'm going to hand it over to you.
Okay, so I will go through the questions. I'll start from the top. So this is from Shelley, and Shelley's question is, you mentioned dementia frequently when referring to the gene mutation associated with ALS. Are the two diseases connected somehow?
I'll let you take that one, Nancy.
Okay, so I'll keep going. You can hear me, right? Because you guys went off
Yeah.
the marker there. Okay, so are the two diseases connected somehow? I have a family history of dementia. However, only my mother had ALS.
Yeah, so, you know, back before we identified the C9 gene, we thought they were completely unrelated, right? We would ask specifically for a history of ALS, and if they said no, then the answer was no, and we didn't do any genetic testing. When the C9 or F72 gene was discovered back in 2011, they saw that that particular gene was related to not only ALS, but also frontotemporal dementia. Okay, so frontal FTD. FTD is very different from Alzheimer's. When we take a family history, the reason why we ask about Alzheimer's is because sometimes the names kind of get mixed up, but these are two very different causes, different diseases, different clinical outcome. So basically, when the C9 gene is involved, one person can either have only ALS, another family member can develop only FTD, and then there are some people that may have a mix of the two conditions. Okay, so a person may get diagnosed with ALS with some clinical description of FTD and vice versa. But outside of the C9 gene, anybody with ALS, a small percentage of people may show some symptoms of FTD, but not enough to call it FTD, and vice versa as well. So it's almost as if there is a spectrum between ALS and FTD, both on the clinical side, but also on the genetic side. Okay, so this is specifically for the C9 gene. For SOD1, we do not see a family history of dementia related to it, as well as FUS, as well as Ataxin 2. Okay, so this is very specific for the C9 gene. This is why we do ask if there's a family history of dementia when talking about ALS.
So Shelley would like to say thank you for all the amazing work you're doing and advocating for increased access to genetic testing. This is so important to those living with this awful disease and to their caregivers. Thank you very much, Shelley.
Thanks, Shelley.
Okay, so the next question is from Wanda. My husband has ALS. Oh, I'm sorry, my screen just went down. Although questions are rolling in now and it's bumping me out. My husband has ALS. His father had ALS, yet genetic testing of 20 genes showed no familial connection with ALS. Is there more testing that can be done? Thank you.
Depend on when the last testing was done in the affected individual. As Nancy just mentioned, the C9 or F72 gene was only discovered in 2011, so just 10 years ago. And even getting that routinely onto some of the testing panels took longer than anticipated. So if it was several years ago that genetic testing was done, it is possible that there might be some new genes available to test today. If it was recent, you know, in the last, I don't know, maybe 5 years or so, would you say, Nancy, there would probably not be anything new to test. But if you recall that pie chart that I showed at the beginning in the portion of the disease that is clearly hereditary, there are still cases of hereditary ALS that we don't have a known cause for. So I hope that answers your question. And Nancy, if you have anything to add, please go ahead.
Sorry, ladies. Wanda just added that the testing was completed in January of this year, 2022.
Pretty up to date. So in those cases, what we would do in our clinic is refer to research because when there is a family history, especially parent to child, Again, this is a rare disease, so to see parent and child affected with ALS, there's got to be some underlying connection between the two. And for us in genetics, we think that there should be a gene. So definitely participating in research research projects and trying to identify new genes.
And there are several labs in Canada who do that type of research specifically to try to identify new genes.
Okay, thank you. Moving on, this question is from Stacy. Now this question is specifically about C9F72. If a non-symptomatic person is positive, does this mean they are either a carrier or will develop symptoms? Is there no chance of developing?
Yeah, so I mean, we'll say they're a carrier for as long as they're not symptomatic, right? But most likely this person underwent predictive testing. The numbers we give, we'll say it's almost 100% penetrant, meaning it's almost 100% the person will develop one of the two conditions. The reason why we say almost is because there's always that one person in literature who reached age 9 years old and still hasn't developed disease of either one. So typically we do say that this gene is fully penetrant.
Okay,
The issue is with predictive is that we're not able to say what age the person will start showing symptoms, if it will be a slower or a quicker type of ALS, or will it be FTD. These are all predictions that absolutely no one can make. All we can say is that the gene mutation is present or it is not. And then this is why the predictive counseling session is so important. So the person has all this information to be able to make that decision and handle this waiting.
Okay, thank you. This question comes from Charlene, and Charlene would like to know, is this testing available in London? There's no past ALS in family.
Okay, so I'm going to assume that Charlene is affected by ALS or caring for someone affected by ALS. In the London clinic, so it's in Ontario, so we have that issue where anything that goes out of province needs to have Ministry of Health or MOH approval. And so there's been some inconsistency with how to get that done, how to get it done quickly. It takes months in some clinics and it can be relatively quick in other clinics for anything that goes out of province. But as I mentioned, the C9orf72 gene is now available to be tested within the province of Ontario. So because the testing is done in the province of Ontario, it just needs a specialist to order that genetic testing. It's done at North York General Hospital, but the blood draw is done locally where the person lives, and then it's shipped to North York General Hospital. So I would encourage you to ask your neurologist if at least C9orf72 could be tested. In this case, because you're just testing one gene, if it comes back as negative, that's not to say that there might not be other genes involved. We just perhaps can't test for them in Ontario at this time. But C9 is available, and it is the most common cause of ALS in sporadic individuals for a genetic cause. So it should be something that you could ask your neurologist about.
Okay, thank you. The next question is from Andrew, and it says, is there any way to understand the naming of genes? It seems random.
Nancy, I'm going to punt that one to you because I have no idea.
There is some logic to it. I mean, sometimes there's the name of the protein, and basically the name of the protein, they'll kind of just take an abbreviation of it, and then that is the name of the gene. Sometimes, for example, epilepsy, there's like so many genes related to it, and so they just, it is random numbers, or most time it is abbreviations to something.
Yeah.
And they add numbers to differentiate between, the first gene that was identified compared to gene number 60.
So like SOD1 stands for superoxide dismutase, which is the name of the protein. So they've abbreviated it to SOD1. But in the case of C9, we don't quite know or understand what that protein's function is in the body. So it's an abbreviation of where it's located in the gene. So it's like open reading frame. So that it's just an abbreviation in that case.
Okay, thank you. The next question comes from Pamela. My father has ALS in British Columbia. The neuro said no genetic testing is needed. Can we get tested outside of the province? I, his daughter, have some bulbar onset symptoms, but not diagnosed.
Yeah, so British Columbia is another province where historically we've really struggled to get access to genetic testing. However, there is a genetic counselor who works in the Alzheimer's clinic, the UBC Alzheimer's clinic, who is very open to receiving referrals for ALS cases. Her name is Emily. If you want to send me an email, I can give you the information on how to, like where the referral would need to be sent. So you would need to ask your doctor, your neurologist or another doctor to send a referral to the UBC Alzheimer's clinic to the genetic counseling team there, and they can help arrange testing. Testing is not straightforward in British Columbia, but there's a couple of options available. As I mentioned, there's that sponsored testing panel, which could possibly be used, but there's also private pay options if patients have insurance. So BC is still a province that we're working very hard to try to get access, and the genetic counselor there has been extremely helpful in offering to see these cases, which has been a huge improvement compared to 2 years ago.
And also to add on, for anyone, any family member that has a family history and they're concerned about having symptoms themselves, it is perfectly appropriate to push their family physician and meet with a neurologist specialized in ALS, just to evaluate the bulbar symptoms that this person is having, right? It may or may not be related, but because of the family history, it's not something that you want to kind of ignore. It's kind of like one of those things when you go see your family doctor and they're asking if there's a family history of heart attacks or cancer. If you say yes, if you say mom had breast cancer, then you'll be offering mammographies at an earlier age compared to general population. The reason why screening is offered is because there's screening to offer. For ALS, that mentality is, well, there's not much to do, therefore, what's the point? But it's perfectly acceptable to ask and push and to meet with a neurologist regarding any symptoms that you may feel be related to ALS.
Okay, so the next question comes from Daryl. If you have a gene mutation linked to your ALS, for example, SOD1, do other treatments available for sporadic patients like edaravone or even AMX0035 have any value?
That's a great question, Daryl. It's possible. So these other treatments that have been approved for ALS or submitted to Health Canada in the case of AMX35, they target pathways which we believe are involved in ALS in some way and are maybe not always clear. That's a big difference with drug development between the purely sporadic causes with no genetic gene involved and those that have a gene mutation. When we're developing therapies for a gene mutation, it's very specific. We know what we're targeting and we know exactly why that's causing the disease in most cases. And when we're developing therapies for ALS where we don't know the cause, remember that slide I had with all the little pathways all linked? That's very complex, all of that underlying biology. And so developing drugs that target somewhere in there is also complex. And because we still don't understand what causes ALS, we're not targeting something super specific. So because, at the heart of it, it's motor neuron health that's affected in some way. Other therapies that are approved or investigational for ALS that are not gene specific could possibly have an effect, but they're not as precise as something that's a genetically targeted therapy. In terms of specific studies looking at that, as far as I'm aware, none have been conducted. For example, I'm not aware of any studies that have tested edaravone efficacy specifically in individuals who have a genetic mutation. So as long as something's deemed to be safe and is approved, I would say that people can explore taking that if that's what they'd like to do, but just remembering it's not as specific. And so if there are other therapies available in clinical trial, those will be more specific to their gene mutation if they have a gene mutation.
Great. Thank you so much, Christiana. There's a question here from Glenn. Is there any correlation between age of diagnosis for the elderly over 80 and the gene mutation?
I mean, typically the older, if you look at ALS in the general population, the sporadic form, and this is true for any disease, right? Not just ALS, but every disease has the typical characteristics of what we should be seeing in the general population. For ALS, when there's one person affected in the family over age 50, this is the typical onset sporadic form of ALS. You would think the older the person is, the less likelihood there is a genetic form to it. That's the mentality around it. And the main reason for it is because diseases are never due to one risk factor or one cause. The way I look at it or think of it is, and it's true like for Parkinson's, Alzheimer's, cancer, but it's mostly like an accumulation of different risk factors that have accumulated in a person's lifetime. Age and family history are the two biggest risk factors for all diseases. So the older we are, the more likelihood we have of developing a disease, right? The body just slows down. For one person's ALS, for another person's Parkinson's, for another person, it's going to be a heart attack. So we tend to think the older the person is, the less likelihood there is of a gene causing it, but that's not always the case. Okay, sometimes we have identified a gene in the family and the person was quite elderly and they just so happened to develop disease at a later age compared to the other family members. This is why for ALS, when we take the family history, the way the person presents with ALS is not enough to determine whether a genetic form or a genetic cause can be identified or not. It really is there a family history or not? If there is a family history, then there's an indication to do genetic testing for the full rounds, just because the genetic forms of ALS and the non-genetic forms of ALS look exactly the same to the physician. Okay, there's actually no clinical difference between the two. So age, it can or it cannot be related to a gene or not. I would probably go the other way. The earlier the age of onset is for ALS, the more likelihood there is of developing ALS. The more likelihood there is of identifying a gene.
Thank you, Nancy. I have a question here from Stacy, and it's specifically about C9orf72. If a non-symptomatic person is positive, does this mean they are either a carrier or will they develop symptoms? Is there no chance of developing, I guess, developing symptoms is what you meant there, Stacy?
I think this question was already answered, right? Wasn't this question?
Okay.
I think Melissa asked that earlier.
Okay, thank you. I'm going to go back up because I do see some here. Please let me know if this has already been asked. Can you comment?
If that question wasn't asked, Stacy, please put it in again if something's still unclear.
Perfect, thank you. Was the question asked about stem cell therapy?
No.
No, okay. So Kim has asked this question. Can you comment on stem cell therapy introduced intravenously? Also, I am the person living with ALS. If my kids test positive for the TDP-43 gene, are there any preventative measures they can do to decrease their chance of onset? And then there's question marks, lifestyle, diet, supplements, meds.
I'll maybe start with this one and then pass it to you, Nancy. So in terms of stem cell therapy, there are no stem cell therapies being developed that target genetic mutations associated with ALS. So they wouldn't be a genetically targeted therapy for ALS. Really, the three categories of types of therapies are the ones I outlined today. So antisense oligonucleotides, antibodies, and gene therapy that target specifically the genetic forms. So I'm not really well equipped to answer a general question about stem cell therapy in that sense. It's not a genetically targeted therapy. In terms of TDP43, I'll pass this to Nancy. You know, if you can add in the comments if you've been tested and that's the mutation that's been identified, then if you're symptomatic with ALS and that's the mutation that has been identified, then yes, your kids could seek predictive genetic counseling. And in terms of, you know, lifestyle changes, preventative, there's no preventative therapies for TDP43 specifically in clinical trial right now, and nothing's been identified concretely, and I'll let Nancy elaborate in terms of preventative lifestyle changes, etc. Nancy, you can add.
Yeah, not much more to add. I mean, you know, healthy lifestyle like every other disease, nothing specific related to the gene. We do know that this particular gene in general, I'm just going to make a general comment because I don't know what mutation exists in the family or not, but this gene is not fully penetrant, meaning it's not like the C9 gene. With the C9 gene, we expect, you know, parent-to-child transmission and the person will develop symptoms. TDP has a reduced penetrance, meaning, and we don't always know exactly what that percentage, the lifetime risk of the person developing the disease. So it may be that the person just doesn't develop ALS and another person does, and we don't know why one person will and one person will not. Could it be lifestyle? Possibly, but could definitely be other risk factors, other biological risk factors that we're not aware of, or even environmental risk factors that we're not aware of.
Mm-hmm. And I'll take this opportunity to mention, because you asked about preventative, there are no preventative therapies for TDP43 specifically right now. There is a clinical trial that has started for, as Nancy alluded to, pre-symptomatic treatment. Right now, that's only for the SOD1 gene. So there is a pre-symptomatic clinical trial that has started where individuals are monitored for certain biological changes over time. And if those biological changes go above a certain level, just to keep it all simple, treatment is initiated, seeing if prevention of disease can happen, prevention of onset of ALS symptoms. Right now, SOD1 is the only ALS-associated gene mutation for which there is a pre-symptomatic trial. It's very exciting. It's very early stages, but potentially this can be expanded to other gene mutations in the future, depending on how drug development goes in this area.
Thank you so much, Nancy and Christina. There's a question here from Glenn. He wants to know, what is the gene penetrance for identical twins in ALS?
I love twin study.
So gene study, so no specific gene identified, just twin studies.
I think,
yes.
Like, what's the probability that both twins will get? Yeah, Nancy, I'll let you.
Yeah, I go for it, Christina. I just know the genes.
In general, identical twins will have identical genetic makeup, so they would both have the mutation. So both would be at risk of developing ALS. And then it will depend on the gene in question and what the penetrance of that gene is. So if it's a gene that has, let's say, 90% penetrance, there's that 10% wiggle room where it's possible someone does not develop ALS. And so even though the twins have identical genetic makeup, they both have the genetic mutation, it would technically be possible that one of them does not develop the disease while the other one does. I think a great example of this would be, there's a very well-known FUS gene case in the United States, the Hermstad family, where there was identical twin girls. FUS, as we mentioned, is associated predominantly with juvenile ALS, so at a younger age. So one of the girls developed ALS symptoms when she was a teenager and subsequently died of the disease. And so she has a twin sister, and the twin sister only developed ALS when she was in her 20s, so several years later. So even though they were identical twins with identical genetic makeup, even the age of onset at which they developed the disease was different. And a very interesting case, the clinical trial of the antisense oligonucleotide ongoing right now for the FUS gene is based on that family that drug was developed. So all that to say, they have identical genetic makeup. They would both have the mutation, but depending on what the penetrance is, and we would obviously need to know more about what that gene is, it is technically possible that one develops the disease and the other doesn't.
Thank you. I have a question here, and the person is asking, I had my testing done at MGH in the USA in 2018, and it came back all negative. Should I do it again? I'm a 12-year patient.
2018 to today, not a lot has changed. There's likely not any new genes that would be tested, but it depends on what kind of panel was ordered. So as Nancy showed in our clinic, if there's no family history and it's an isolated case, we now test C9, SOD1, FUS, and Ataxin-2. However, we only started testing FUS and Ataxin-2 within the last year or so because the clinical trials started. So this person could bring their report, which would indicate on it what genes were tested, to their neurologist to consult on what exactly was tested and whether or not anything new would be available for testing. If it was a broad panel of 40 genes, probably not. But if it was just, let's say, SOD1 or just C9, then there might be other options for testing today.
Thank you. So we have a question here from Mariah. In our situation, my grandfather was diagnosed with ALS and my father was diagnosed with PMA. My grandfather has both upper and lower motor neuron symptoms, whereas my father only has lower motor neuron symptoms. Thus the difference in diagnosis. My father has tested negative for the ALS genetics panel. In your experience, would you expect that this is still potential to be a genetic cause if one has typical ALS and one has PMA?
So if I understand correctly from the question, the father has PMA and he's the one that's had the testing, right?
Yes. And then the grandfather was the one with ALS.
With classical ALS with both upper and lower motor neuron involvement.
Yes. And the father tested negative on the ALS genetics panel.
So, PMA is kind of like in a spectrum of disorders with ALS where it doesn't quite meet that diagnostic criteria because there's no upper motor neuron involvement, but it has a lot of the same symptoms, oftentimes progresses a little bit slower than classical ALS. There's always that possibility, but it's really hard to say depending on, without seeing, like the clinical presentation of the cases and what exactly was tested. I don't know if you have experience with this, Nancy.
Yeah, PMA, is that similar to PLA, like primary lateral?
But yeah, it's primary muscular atrophy. Yeah.
Yeah. So again, yeah, I agree with Christiana, right? Like there is a spectrum. Not all of the spectrum is related to a genetic form of it, right? So this one really would be for the neurologist to ensure that the clinical diagnosis fits with the genetic form of ALS. If ever there's an evolution of symptoms and the PMA is starting to look like something else, then the other genetic forms of other conditions need to be considered, but this would really be for the neurologist. But for the symptoms that he's having presently for PMA with a family history of ALS, the appropriate genes may have been tested for already. So there wouldn't be anything else to do unless your father or the person who's alive today has an evolution of symptoms that may look to be different in the future.
Great, thank you. And Glenn is asking, is there a gene for the PMA diagnosis?
No, not PMA specifically. It's in that spectrum that Nancy mentioned, PLS as well, primary lateral sclerosis. If you have ALS in the middle and you have both upper and lower motor neurons, PMA has just lower motor neuron involvement and PLS has just upper motor neuron involvement. And so we can sometimes see patients eventually develop the other involvement. So like PLS becomes ALS because lower motor neurons are now involved, and PMA can become ALS. So it's all in the same spectrum. There's no genes that have been identified as associated specifically to PMA or specifically to PLS. In our clinic, if somebody had a PLS or a PMA diagnosis, they would be offered the same genetic testing as somebody with an ALS diagnosis. And we see these patients all in the same clinic.
Yeah, and sorry, the person had this for 12 years, if I remember. So yeah, the slow progressing type of ALS, just to kind of let everyone know that there isn't specific genes found for the slow progressing ALS. It's almost as if it's a different category still always under ALS, but the genetic forms for the slower ones, the ones that go on for 12, 20 years, there are no other types of genes or different ones.
Thank you, Nancy. There's a question here from Julie. I lost my mom to ALS in June 2020 in Victoria, BC, and I find my doctor does not know anything about ALS. I have been waiting for a neurology appointment for over a year now, as I have seen some signs in myself. Is there any doctor in Victoria, BC that that has more experience with ALS that people can see or be referred to by their doctor? My mom's biological father, who we don't know, has passed, but she found out some family history. So she has some unknown family history, and she's hoping to have a contact where she can be referred to by her family doctor. Yeah. She also adds a family member of his, so of her mother's father, had said in a first initial phone call that she also may have lost her grandfather to MS. So she wonders if that could have actually been ALS. So she feels quite lost in Victoria and really is hoping to have a referral to a specialist in Victoria.
Yeah, I'm not aware, and it's possible there is, I'm not aware of any neurologist or clinic. There's no clinic for sure. There's no ALS clinic that I'm aware of in Victoria. It's possible that there's a neurologist following patients in Victoria, but again, I'm not aware. It's possible that I just don't know. In British Columbia, the two clinics that I'm aware of are the one in Vancouver at GF Strong, and there's also a neurologist who's starting an ALS clinic in Kelowna as well. So if you're able to travel off of Victoria Island into Vancouver or Kelowna, you could ask for a referral to one of those two clinics. I think if you're feeling like you're experiencing symptoms, you should be addressing the symptoms first with a neurologist as opposed to seeking genetic testing first to confirm if you are indeed experiencing ALS symptoms and have that really confirmed and nailed down, because otherwise it's a predictive testing. And Nancy and I have definitely dealt with cases where a family member had MS, and MS was misdiagnosed in older generations and progressed more rapid than it should have. We've definitely seen those cases, so that's something really important to mention as well. So I'm sorry I don't have a name of a neurologist in Victoria, but I do know that there are two clinics. There's one in Vancouver, one in Kelowna, and so you could ask for a referral there. And the most important thing would be to have your symptoms addressed first.
Wonderful, thank you. And there's another question here from Mariah. I apologize if I've missed this answer, but do you have any information regarding CRIS, PR, and ALS genes?
Sorry,
I don't
CRIM.
know if it's meant CRISPR or CRISPR.
CRISPR.
Or CRISPR.
So, yeah, CRISPR is a technology to edit our DNA. The new technology, it's a very hopeful technology to really go in our genome and remove any gene mutations that we have and to correct it with a proper reading. Still in research, not available in clinic in any way, shape, or form.
Yeah, it's very, very early.
Lots of hope, but still very much in research. I don't even think I think they've only used it for one human trial for one particular disease at most, and not available for ALS, that's for sure.
Yeah. Extremely helpful technology for fundamental research and better understanding of ALS. Extremely, extremely important. The discovery of CRISPR was a huge milestone for all of research, not just ALS, but extremely experimental in terms of use in humans. I'm sure it will get there someday. It's a little daunting to think about editing someone's genome, and I'm sure we'll get there, but it's going to have to go through a ton of safety trials first. Even just looking at gene therapy, which is something I talked about, there are no approved gene therapies in adults because we have more robust immune systems than children, right? So there's just a hurdle with something that's much, much further ahead than CRISPR. So as Nancy said, very hopeful, very exciting, but we're not there yet at the stage of human trials.
Thank you, Christiana. I'm not sure if this was already asked, but Wanda's asking, my husband has ALS, his father had ALS, yet genetic testing of 20 genes showed no familial connection with ALS.
Yeah, we got this one earlier.
Okay, perfect. So I'll mark that off. And I know I just want to acknowledge that accessibility-wise, that it may be difficult for some people to type. If you do have speech-to-text software, that should be able to enable you to get your questions into the chat box, or you can send me a message and I'll ask that question. It looks like, from what I'm seeing here, Christiana and Nancy, that the questions have all been addressed. I'm just going to give people a couple of minutes. We're at 2:56 and the webinar will end at 3 p.m. So if you do have any last minute questions, if you can please type it in to the question box or use your speech to text software to do so. I will continue to look through and scroll through. There is so many questions. I mean, this is such a hot topic, and I have learned so much from this webinar.
We really appreciate the opportunity to share this information. So much has changed just in the last 2 years. I know someone said thank you for all the work that we're doing. I'm so glad that we have been able to make change, and I also recognize that it's still not enough. There's still so much work that needs to be done in terms of equity and access to genetic counseling and testing. We have a shortage of genetic counselors in Canada. You know, as you heard from Nancy today, I've had the privilege of working with Nancy for many years now, and the care and the dedication that she gives to patients in giving this information, delivering challenging news, it's such an important specialty. And so we've not only been working to just get access to genetic testing, but we need better access to genetic counseling as well, regardless of who that comes from, a genetic counselor, a neurologist, et cetera. And so, you know, we really, there's a lot more work to do. And I think my email address was put in the chat box for everyone. If you're having difficulties accessing genetic testing or counseling, I may not be able to solve it, but I would love to hear from you because that helps us target where advocacy is still needed.
So ask and you shall receive, naturally.
Yeah.
Chia has a question. How do you approach family members if their first-degree relative is deceased and their genetic status is unknown?
Nancy, that's a tough one.
It is a tough one. It all depends if there's a family history or not, right? If there's only one person in the family with ALS, typical age of onset, typically as of yet, the recommendations are to not offer genetic testing for the unaffected family members. Genetic counseling can be available to talk about potential risks, but as of yet, to order genetic testing in someone who's asymptomatic or not affected, and there's only one person in the family with ALS, the recommendations are to not test. Of course, there's always that gray zone. We're not sure the family history. There's always exceptions, but we have to understand that we're entering predictive testing. This is not a clinical test. This is predictive in the sense of, are you ready to know? And my biggest question is, am I ordering the right test, right? For me to say the test is negative and I didn't order the right test is a huge liability on myself, and also, am I doing the right thing? So that's why when we order testing someone who's unaffected, it is so important that the gene be identified already, and I know exactly what gene, what mutation to test for. And my answer really is yes or no, you have the gene or you don't have the gene. I know ALS is a fast disease. People who were diagnosed many years back didn't have access to genetic testing, so we are fully aware that isolated case of ALS, they didn't have genetic testing, but we have to remember the purpose of doing genetic testing for isolated ALS really is for clinical trial purposes, to offer a prevention or a potential new treatment to treat the disease. We are not there yet where we're offering testing for everyone with ALS. Okay, this is true for breast cancer survivors as well, right? Like or ovarian cancer or anything in genetics. We're just not there yet where we can offer genetic testing to the unaffected population yet.
Mm-hmm.
I think one day we will get there, but we're just not there yet today. If there is a strong family history of ALS and genetic testing was never done, and there is a person in the family who's interested in having predictive testing, we can have a little bit more of a discussion, because when there's a family history, there should be something, there should be a gene in the family. And so the likelihood of identifying a gene is much higher in that person than it is if there's only an isolated case of ALS. So these discussions can be had, but we're not guaranteed, we're not promising that we will offer genetic testing, but risk counseling and the discussion and having the genetic counseling is so important. It could be important for certain family members, for certain people who are this answer.
So this is also a nice plug, if I can, for participating in research. If your clinic offers DNA banking, if you're not ready for genetic testing as someone who's living with ALS, but it might be something for your family members in the future to have your own DNA banked for research purposes. We've had some cases with the genetic counselors in the Maritimes where an individual has come forward and said, like, I have a family history, but no one was ever tested. This was years ago. No one ever got any genetic testing, and now I would like to know this. And we've gone back and looked and see if there's banked DNA samples, and those samples from the affected individuals could be tested. And so that gives us more information to kind of handle these challenging situations. And so if somebody is considering genetic testing, but they're not sure if they're ready for it right now, banking DNA can be really helpful for future generations.
Well, and just being mindful of the time, thank you so much, Christiana and Nancy, for your very comprehensive overview. I'm sure that there are still more questions, and Christiana's email is in the chat section there. But like I said, this webinar is being recorded and it will be uploaded to our website. And we really would like to thank all of you for sharing this time and this space with us. Stay tuned for more upcoming webinars through our ALS Community Services webinar. I'm your host, Rochella Watson, and I hope you enjoy the rest of your afternoon. Thank you so much, Christiana and Nancy. Bye, everyone.
Bye.